This video is going to serve as an introduction to the study of gross anatomy and a bit of anatomic terminology. It is going to focus on some widespread aspects of the human body, as we are going to really in this course be focusing on regional anatomy, what you find in each region. This is going to essentially be a review of some important concepts from undergraduate level A&P courses, the prerequisites that you have to get into the PA program. Right. So I'm going to start with this, and I'm not going to read through all of this, but this is really just going to be a reminder that when we are looking at all of the different terminology that we'll be experiencing throughout the course of this session, that the words have meanings. And I'm sure you know, a lot of these words are going to be made of a combination of a prefix, a root word, a suffix, and these are going to have different meanings. So it's really useful, of course, because to know what these words mean. Very often, the root of a word goes from an old descriptor of what that region actually is. All right, so just sort of a general reminder of terminology, and actually you'll also see a lot of positional terms in here as well. All right, speaking of position, anatomic position or anatomical position is standing upright, feet together, facing forward, eyes looking straight ahead, and palms forward. Right, and that's kind of the weird thing. If you're standing in an anatomical position, it's not necessarily just standing up, but the palms are forward. In what we would say, the palms are in the supine position. Now, supine can also be a reference to the entire body being in an anatomical position, but laying flat on the back. Right? Prone would be roughly anatomical position, but laying flat on the belly. All right? And as you deal with patients, in written instructions and such, you may say for an examination, supine, prone, depending on how they have to actually be examined. All right, a whole big list of general regional terms. And as you are looking through this, right, you'll note that a lot of the terms are going to relate to the bone that is underneath, or you may see the name of a muscle that you happen to know is in that region. I think in the general case, the name of the region came before the name of the muscle, but it's all related, right? So some examples with the bone. All right, we see sternal right in the middle there. All right, femoral for the thigh. Okay, a couple of these other ones, like where is it? No, it's actually probably not on the. Here we go. Olecranon, relating to the back of the elbow. Well, there's an olecranon process that we'll find on the ulna, so not necessarily just the name of the bone, but we see a bone feature on there. And again, which one came first? Who knows exactly. We're going to see cervical for neck, all right, the thorax, thoracic in this whole area here, the abdomen, all right, just kind of some general terms here I'm throwing out here for muscle relations. We see pectoral, we see gluteal, all right. One kind of additional thing here, the trunk, all right, thorax, abdomen, pelvis, and actually that's going to be the first things that we're going to be looking at after this. When we really start getting into things, we'll look at the trunk region, thorax, abdomen, pelvis, and the perineum of the pelvic floor. Then you look at the limbs. The best way to describe this would be the upper limb or upper extremity, sometimes you'll see that, and lower limb or lower extremity. Saying arm or leg, now obviously we say this a lot colloquially, arm for the entire upper limb, leg for the entire lower limb. That's actually not correct in the anatomic sense, and where it may matter is when you're running into, again, some of the technical terms. So the word for arm is brachium, or we can say brachial, right, as the adjective. Right? The muscles that are in there, things like biceps brachii, triceps brachii, have that in there. The brachial artery, the brachial vein, etc. Right? Antebrachial means the forearm, and it's just here from the elbow to the wrist. Right? And then you add on other things, including the carpal region, the wrist, right? The hand, which you could say the manual region for the hand, right? Things like that. So it may actually matter of, say brachial versus antebrachial. What that actually means is arm versus forearm. In the lower limb, we do have the femoral region or thigh. The leg is actually this curl region, right? So what you would probably call the lower leg, all right? But if you're saying curl or leg, it's actually, between the knee and the ankle. The best way to remember that, of course, is to just go to Royal Farms and get yourself some fried chicken. Thighs and legs, yeah, it's those regions. All right, just, of course, on the chicken. Okay, general directional terms, all right? Superior, above. Inferior, below. Anterior is front. Posterior is the rear. Okay. There are some other terms here. You'll see cranial versus caudal, dorsal versus ventral. Cranial, caudal, dorsal, and ventral are in reference to specific body surfaces or areas. The cranial region, that's easy, right? Cranial, head. So if you're saying cranial as a direction, it means towards the head, which on a human is superior. Caudal is tail, and of course we don't really have much of a tail, just that little remnant of the coccyx. All right, but if you're moving towards that direction, that would be caudal. Dorsal is the back. Now note, I said posterior is rear, dorsal is the back, the actual structure, which is going to be the first thing that we'll actually be talking about on Wednesday. Right? Whereas ventral is the belly surface, the venter. Okay. So again, in a human, ventral is anterior and dorsal is posterior. Not always the case, though. Now, this is, you guys are in a PA program, you're focusing on humans, so, but if you have an interest in other organisms, whether it be, let's stick with vertebrates here, but like dogs, cats, horses, fish, whatever, the anterior part is actually cranial, all right? It's not ventral, all right, because of the horizontal orientation. So you have to be a little careful. Usually we'll say anterior and posterior. Dorsal and ventral, though, those words do rear up a few times, especially in relation to the spinal cord and other neural structures. And this is in part due to, in studying neuroscience and using models with fish and mice and other things like that, in order to maintain consistency in the terminology, dorsal and ventral is used. All right. Of course, bilateral symmetry, we have a right side and a left side. Medial towards the middle. Now, one thing that is actually not here is median, which would be an actual midline feature, medial towards that midline. If it's actually on the midline, you would say median. Lateral towards the side. Proximal and distal are best used in limbs. Proximal towards a source, in this case the trunk, really. Distal further away from. So distal kind of sounds like distant. Proximal kind of sounds like approximate, right? Closer to, further away from. Right. The limbs are the best place where you see this a lot. Sometimes we will see this in certain other places. For example, if you were discussing blood vessels coming off of a main trunk like the aorta, you might say that a certain branch is distal to another branch because it is further down the aorta, further away from the heart, right, with the source where the aorta is. All right, and here is a list of basically everything that was on the other slide, with some additions down here that were not put in, but are a little bit more applicable here as we are studying gross anatomy: superficial and deep. Now, this is a strange semester, of course. It was my understanding that generally the use of the cadaver lab has been the case, all right, and then, next time there's going to be computer images and such, and we're going to work a little bit with some software to try to mimic dissection a little bit, sort of a mimic, no real substitution, honestly. But that's where we see superficial and deep, all right, superficial at the surface, and that's, this is reasonable. It makes sense. We use the word superficial in everyday life. It's just something on the surface. Deep, literally deep. Peel away a layer, see what is underneath. Okay, so you can think about it with dissection and other structures. So towards the surface versus deep. A few other terms, directional terms. Intermediate. Right? Intermediate is anything that is between two other structures. And then these two that have the word lateral in them. So lateral meant towards the side, but sometimes we want to compare sides. And so we have ipsilateral and contralateral. Ipsilateral means on the same side, meaning two structures are both left or two structures are both right. Or in talking about movement, for example, right? The erector spinae group, all right, there's some muscles on the back. When they contract, you would get ipsilateral flexion, right? Meaning if the left group of the erector spinae contracts, then the vertebral column bends to the left, right? And then contralateral would be the opposite side, right? So, for example, the sternocleidomastoid muscles, if you use both of them, you flex the neck down, all right? Whereas if you only contract one set, you get contralateral rotation, contracting the left sternocleidomastoid causes the head to kind of rotate towards the right, for example. All right, sectional planes. Sectional planes can be used to divide the body into two parts. Now, if you were dissecting and such, this could be done literally with sharp implements. All right, but of course, if you have a living patient and you want them to remain a living patient, we will be thinking about sections using imaging technology, right? But to develop planes so that we can better see what is inside. The sagittal plane, the frontal plane, the transverse plane. Sagittal is going to divide the body into a left portion and a right portion. Not necessarily a half. If it is a half, the better term would be mid-sagittal. If it is off the midline, we can say the term parasagittal. Now, we're looking at this in terms of dividing the plane, but any kind of motion, actually, that would fit on that plane could also be called mid-sagittal, parasagittal motion, or certain other things, although I can't think of anything right off the top of my head. But with the motion, what I'm actually thinking of is walking, just regular gait. All right, we have our limbs tucked underneath us, and they would be moving in a parasagittal fashion. All right, or if you just stick your arms out and you're doing kind of like chop motions or something, parasagittal. All right, because off the midline, but it's kind of what you would say generally straight up and down. All right, or within that plane. The frontal plane is going to divide the body into an anterior portion and a posterior portion. So we see this full body frontal plane right here. A lot of times frontal planes would be taken of the head and neck. This is where you may see a lot of these in doing certain types of brain scans, in which case they are often called coronal planes, right, or the coronal section. The term corona, corona, it actually means crown or halo, all right? So, of course, the coronavirus that has disrupted everybody's 2020 is surrounded, has a corona, a halo, of the little spikes that, they call them spikes, that let them grab onto various receptors on the body and be a problem. But if you want to think of more nicely here, like a halo, a crown, all right, around the head, that's kind of where that term comes from, coronal plane. Finally, the transverse plane, or a transverse section, goes horizontally, all right, and whenever you see the word transverse, always think horizontal. Something is going horizontally. So this will be dividing the body into a superior portion and an inferior portion. Transverse sections are usually called cross sections. All right, so throughout the course, there are going to be a lot of cross-sectional images shown, as it's a pretty useful tool to see kind of what is at a specific vertical level. So here, just a little chart showing again kind of everything that I mentioned on the previous section there. Transverse, horizontal, cross section, sagittal being mid or parasagittal, and the frontal plane, which can be called a coronal plane. When cutting through organs or other structures, sometimes it is useful to use the terms longitudinal section and, again, cross section. And the distinction here is relative to the long axis of the organ. So if you want to think about something very long, for example, like a section of intestine, gut tube, if you section parallel to the long axis down the tube, right, then you have made a longitudinal section. If, however, your cut is perpendicular to that section, then it is a cross section. Anytime the word oblique is used, of course, just means diagonal, and this could be a whole body or on an organ, all sorts of things. Now, we're not doing histology studies in here, but as you go forward, you may see on the descriptor of any kind of histology slide LS or CS for longitudinal section or cross section. Looking at the 11 body systems. This is just a quick review. If you've taken, and I know you have, other A&P courses, anatomy and physiology, when studying them together, it is usually studied with the systemic approach. Body system by body system, looking at the organs of each system and seeing how they are all working together for some major job. All right, a lot of little jobs adding up to the big job. All right. We're going to be studying regional anatomy, just sort of bit by bit. All right, what is in the thorax, what is in the upper limb, so on and so forth. All right. But it is kind of important to review all of these systems, as all 11 body systems are going to make up one organism. Additionally, when we are looking at, say, especially something like the thorax or the abdomen, we're going to see components of all 11 body systems in that area. A lot of these body systems, bones, muscles, nerves, blood vessels, lymphatics, things like that, are found everywhere. And as we're going to be looking at this kind of review of the different body systems, we're going to be paying close attention to those kinds of structures, since we're going to be seeing them over and over and over again, to look at their structure and figure out what they are really up to. So I've got just two general slides here showing the different body systems. Right here is just kind of a diagram laying them all out here. The integumentary system, skeletal system, muscular system, nervous system, endocrine system, cardiovascular system, lymphatic system, respiratory system, digestive system, urinary system, reproductive system. This is also showing, you could see here, the textbook where I got these slides from, organ level, organism level, and in between, organ to organ, system to organism. What is below here are tissues, and I want to just make a note that tissues are going to make up the organs. Organs are complex structures made of two or more tissues. I am not going to be talking about tissues here. I did, however, include a, probably more verbose than it ought to have been, but whatever, description of tissues, a written guide, which hopefully you guys have read through that, right? It's kind of the reading for the day. Just a reminder as to what the organs are really going to be made of, and especially when it comes to the connective tissues. We're going to see a lot of connective tissue in the body and not necessarily part of an organ, just kind of filling up spaces and things like that. But back to these systems. All right. The integumentary system is the skin and hair. All right. It is a major protector. It's the barrier separating the internal environment from the external environment, and of course has to protect against any kind of damage that could occur from the external environment. It is also, because it is the outside of the body, a location of many, many receptors, sensors tied to the nervous system that are going to pick up information about the external environment. The skeletal system, made of all the bones, is going to be the major support of the body, giving it shape, some protective aspects. It is going to be a place where calcium is stored, also the site of blood cell formation. When we say muscular system, we mean really the skeletal muscles, right? And skeletal muscle organs are going to be made of muscle tissue plus a lot of connective tissue. And these are going to be moving the skeleton. They attach the skeleton, move it around, as the name suggests. They can also generate body heat, or actually rather, a lot of our body heat is generated by the action of skeletal muscles. And some of them are just going to be kind of holding the body up too, as they attach the skeleton and provide tension to hold us upright and support us. The nervous system is all about control, all right, and sort of three aspects of this here. Sensory input to detect changes in the internal environment or the external environment, send signals detailing those changes to kind of a central command, the central nervous system, brain and spinal cord, and their decisions can be made. The processing, that's the big second part, the processing of this information. The third part is motor control, right? Sending out signals to effectors, mostly muscles, muscle tissue of all kinds, but other glands, things like that can be effectors. So that's what the nervous system is all about. Data input, information processing, decision making, and then motor output. The endocrine system is the secondary control. A lot of glands here, things like the thyroid gland, the parts of the pancreas, the adrenal glands, pituitary gland, etc. The endocrine system is a secondary control system. It is going to control body tissues through the use of chemical messengers called hormones. These are going to go into the bloodstream and circulate. Right? And because of that, the control takes a lot longer than the nervous system. However, it can also last a much longer time. So we see slow, continuous processes like metabolism, growth, reproduction, controlled by the endocrine system. The cardiovascular system consists of the heart and all of the blood vessels, right, the arteries, capillaries, and veins. These are going to contain blood, which is the main transport medium of the body. Heart is a pump. Blood vessels contain this blood. Arteries will direct the blood into body tissues. Capillaries are the smallest blood vessels where gas exchange occurs. Veins are going to return the blood back to the heart. The lymphatic system is kind of a weird system. It is going to be made of thin-walled lymphatic vessels, lymph nodes, and a few other lymphatic organs. Lymphatic tissue overall is going to house a lot of immune cells. The lymphatic vessels return extra interstitial fluid from tissues back into circulation as just a matter of exchanging material to body tissues in general. Water volume, plasma volume really is lost from that process, so blood volume would decrease, and this other fluid volume, interstitial fluid, will increase. And so to maintain it in balance, this will be returned via lymphatic vessels. Now, along the way, there is a lot of scanning for pathogens, and that's where the lymph nodes come in, housing these immune cells. Now, please note, there is no actual quote-unquote immune system. Body immunity involves many systems. However, the lymphatic system is the biggest system involved with that you'll see in other places as well. Respiratory system, the lungs, the airway, of course, breathing for gas exchange, right? To make sure that the blood is supplied with oxygen and extra carbon dioxide can be removed from the blood. The digestive system, we eat food, we break it down, and we take all the good stuff and put it in our bloodstream. All right. Why do we eat? Because we need nutrients for energy and for our own building blocks. And it's a very intensive process, a lot of things going on. We'll eventually get rid of the excess, The urinary system doesn't have too many organs in it. The kidneys, ureters, urinary bladder, urethra. It makes urine. And that's it, right? No. The kidneys are really, really important complex organs as they're basically regulating the composition and volume of blood, helping to get rid of excess water, salt, metabolic waste products while maintaining the good stuff, all right? Making sure that we're not just getting rid of things like glucose and amino acids that don't just want to flush those down the toilet. All right, make sure to keep them. Finally, the reproductive system produces sex cells, the gametes, that can combine to make a new organism. And they also actually have major endocrine roles in kind of regulating the processes of reproduction and other things as well. All right. Whew. So the rest of the slides here are going to go through some of the body systems and just show some major features. And again, these are things that are going to be all over the body. So when looking at gross anatomy, they are going to be encountered. So we'll just start in general with skin. Now, we're not doing cadaveric work and so on, but if you ever find yourself in the position where you are going to be doing the dissection yourself, job number one is always to remove the skin. So what are you actually looking at? Well, the skin consists of two major parts. The epidermis, which is a stratified squamous epithelium containing keratin, and the dermis, which is an irregular, dense connective tissue. The dermis is going to hold many other structures, including hair follicles, sweat glands, sebaceous glands, nervous receptors, blood vessels, things like that. Okay. Now, deep to the actual skin, deep to the dermis, is what is sometimes called the hypodermis, or subcutaneous layer, which is going to contain a lot of adipose tissue. And this is going to not really be part of the skin itself, all right, but the adipose tissue, which is going to also, as you can see, have a lot of arteries, veins, nerves traveling through it, more superficial things. Deep to that is where you will actually find the muscles, the bones, etc. All right, generally wrapped in their own denser connective tissue. Right? But this is not part of the skin itself. It is important, all right, you may know, I hope you do, the term hypodermic, a hypodermic needle, right, goes under the skin. Some injections, that's as far as they go. Subcutaneous injections are just meant to be put into this layer, not necessarily into a muscle or a blood vessel. All right, bones. There are 206 bones of the human body, divided into the bones of the axial skeleton, the central axis, meaning the skull, the vertebral column, and the bony thorax, the ribs and sternum. Then the appendicular skeleton, which is going to be the limbs and limb girdles. All right, you can see the division of these bones right here. This has most of the names of the bones, except for what's not actually named are a lot of the ones here in the skull and certain other places. There are a lot of those, and we'll get there when we get to the head to some degree or another. All right, but this is the general shape here, so I hope you guys remember skeletal anatomy. We're going to be looking at the bones region by region. All right, kind of usually start with that because it's the framework that everything else is going to be connected to. The bones are going to be divided into a few categories. We could call them flat bones, which are going to be flat, as the name suggests, generally curved. Things like we see here the parietal bone are on top of the skull. The ribs are flat bones. The scapula and the pelvic bone here may be considered irregular, as they don't necessarily fit nicely into any one category with all the things projecting off of them. You can see on this diagram, you say, okay, well, the scapulae are flat bones, but the pelvis isn't. Sometimes bones are going to be a little bit more complex in their shape. They don't fit neatly into the category. But we do see this nice flat part here. I'm thinking about like the ilium, that region there. It's definitely more like a flat bone than anything else. Right? Two layers of compact bone with a kind of a sandwich of what's called trabecular bone in between, trabecular or spongy bone, which is going to be a location where you would find some marrow. And the marrow that you find in flat bones is actively hematopoietic. Right. The long bones are going to be found in the limbs, every bone in the limbs except for the carpals and tarsals. They do have a long axis, what's called a diaphysis, and then the ends are epiphyses. The irregular bones don't fit in neatly into any category. The carpals and the tarsals are short bones. They're just little blocks. All right, not kind of too much. The bones have lots of features on them. All right, and we'll be kind of covering the most important ones. The surface features will relate to the function. So there may be a lot of projections, okay? Projections for muscle attachment or joint formation. Sometimes you'll have a projection and a depression. One bone projects, another one depresses, and they come together and make some sort of joint together. A lot of holes, though, for the passage of blood vessels, nerves, or possibly other structures. So here are some specific names. A process. All right, I'm going to underline this one. Process is a general term for a projection. There are a lot of processes on the bones of the body. The coronoid process, the olecranon process, just kind of spouting them out. Some of them get special names, though. There are trochanters on the proximal femur, the greater and lesser trochanter. There's the greater and lesser tubercle at the proximal humerus. There are tuberosities in several places. The tibial tuberosity, the ischial tuberosity. Right. Sometimes, if it is long and narrow, it may be called a spine. If it is more elongate, we could say a crest. So if you run your finger along the bony hip, that's the iliac crest. It may be a line if it's a little bit more subtle. Condyle is a term for when the projection is kind of round, and these are often used to make a joint. For example, the occipital condyles on the base of the skull that are connecting to the first cervical vertebra, the atlas. Or the mandibular condyle on the mandible that fits into a groove on the temporal bone and makes the jaw joint. The term ramus is a beam, often has an angle to it. You can see the plural of ramus is rami, right? And there's the mandibular ramus, just the beam of bone on either side. There are rami on the pubis as well. Everything on the previous slide was something projecting out and actually made of bone. So to borrow an art term, it was all positive space made of bone. The things here are negative space. It's when you're wearing bone away to make a depression or a hole of some kind. And two that we're going to see a lot of here, fossa and foramen, not like the other ones are absent, but a fossa is a general term for a depression in a bone. And in terms of joint making, I mentioned the condyle, kind of a rounded, bumpy projection. It may fit into a fossa. So the mandibular condyle on the mandible fits into what's called the mandibular fossa on the temporal bone, and that is the temporomandibular joint. Okay. A foramen is a general term for a hole or an opening. Best foramen example I can think of is the foramen magnum in the base of the skull. Literally, that means big hole. It is a big hole for the spinal cord to emerge from. Foramina is the plural, or multiple foramina. If a foramen is wide, all right, kind of wide but narrow vertically, it may be considered a fissure. I'm just looking at that right now. Wide and narrow. I need to rephrase that. Wide but not very tall, I guess, is the better way to explain that. A fissure. If it is more of a tube, all right, a passage like that or a tunnel is either called a canal or a meatus. This term does have 3 syllables to it. Meatus, not meatus. Right. I did kind of skipped over this one, but I meant to come back. A sulcus is when you have a depression, it's more of a groove. Now the term sulcus, we're here talking in the skeletal system, but you may realize that there are going to be sulci in other places as well. The grooves on the surface of the brain. There are sulci on the heart. It's just a term that means groove. And actually that can be true of many of these other terms. They don't necessarily have to be bone. If you have a hole in another structure, it might be called a foramen. All right. Finally, the term sinus is a cavity or a space. And there are a few sinuses related to the skeletal system, the paranasal sinuses that open up into a few bones. But we're, again, going to see that term for a lot of different structures. All right, long bones have a little bit of extra terminology. I won't spend too much on this, but the diaphysis is the shaft of the long bone. All right. It is made of compact bone. You can see here the cross section of how the bone is really densely packed together and is very strong against bending forces, especially. Each end is called an epiphysis. So these are in long bones, and we usually say the proximal epiphysis and the distal epiphysis. And these typically have a lot of modifications for making joints, holding on to muscles. All right, you'll typically see a lot of different features at each epiphysis. A lot of blood inside. All right, the long bones will have a marrow cavity. Now the marrow in here is actually going to be this yellow marrow that, as an adult, it's going to be yellow marrow, which is mostly adipose tissue. It's actually not the hematopoietic stuff. That will be found in the spongy bone and the epiphyses, as well as in flat bones. But a lot of blood. Bone is kind of interesting because it really, it is alive, it is dynamic, it's very wet, vascular, as I said, it heals. So sometimes just thinking about bones and getting the idea of, dusty old bones in a museum is really not accurate. Not when they're inside of your face and other places, right? A couple of other things here. I skipped articular cartilage. I saw that was on the previous slide. If there is a joint, there will be articular cartilage. We're going to look at joints very soon. But then also the periosteum. You don't really just see the bone, all right, by itself. It is surrounded by a dense connective tissue covering called the periosteum. When we say something is going to attach to a bone, and that something, I'm lecturing with, and you guys can't see, I just did air quotes. That something, all right, air quotes, can be a tendon from a muscle, it could be ligaments holding bones together, but it really doesn't go into the bone itself. It blends into the periosteum. The dense connective tissue blends into the periosteum. The periosteum, however, does embed into the bone itself. And this isn't labeled, but you can see down here the periosteum. And these, what are called perforating fibers or Sharpie's fibers, are actually going into the periosteum. And so you can peel that away, all right, if you were dissecting. It makes it sound like Velcro tearing, honestly. But that's, the structure that all of the tendons and ligaments are actually going to connect into that. And last bit on here, we're not going to get into the real nitty-gritty of microanatomy, but I mentioned the terms compact bone versus spongy or trabecular bone, and that gives you an idea of what you're seeing. You don't see dense aggregates of compact bone except in long bones, in the diaphysis of the long bone. Making up the outside of really any bone, it's somewhat compact, but it's here when you see just a few of these layers together, not these concentric ringed osteons packed together, just a little bit there. And then the trabecular bone or spongy bone is going to be lining the marrow cavity. You'll find it on the epiphyses. You'll find it in the middle of a flat bone. All right, spongy bone is really going to be. Okay, joints. Things are coming together. Joints can be classified in two different ways, and whenever I'm teaching joints, I'll always present this, but I say don't look too hard at this functional classification: synarthrosis, amphiarthrosis, diarthrosis. The functional classification looks at how much movement there is at a joint. The problem is that there can be some, if you'll pardon the pun, wiggle room as to what you really classify one joint or another as. Is this supposed to be wiggling? Is this not? Is that slight movement? I don't really know. So this is not great. Looking at a structural classification is easier because you can say, oh, this is what's holding the bones together. We're going to use this material, therefore I know what it is. And broadly, we could say it's going to be held together with fibrous connective tissue, dense connective tissue, or cartilage. Or there could be a very large, complex structure holding the bone together. That would be a synovial joint. All right. So these are going to be the most important here. But let's look just briefly at fibrous and cartilaginous joints. All right. Some fibrous joints are sutures. These don't really move. Okay. So you would definitely, as this is classifying them as a synarthrosis. Sutures most are found in the skull. In fact, I'm not sure if they're really anywhere but the skull. You've got a kind of a zigzagging line with a lot of surface area and short, tight collagen fibers holding those bones together. So they're really interlocked. They're not going to be moving. Somewhat longer fibrous patches can make what's called a syndesmosis. And these are a bit larger, holding, for example, the tibia and the fibula together. Right. I don't really know how much that moves. Again, this textbook is classifying it as an amphiarthrosis. I'm not sure exactly how much movement is needed to qualify it as that, but whatever. The last fibrous joint is this gomphosis, which I'm not even sure if I would technically call this a joint, because a joint is where two bones come together, and teeth are actually not bones. They are mineralized structures, certainly. They are not made of bone, and developmentally, they come from a completely different place than bone. Teeth are actually developmentally more closely related to hairs than they are to bones. But that's a different story. In any event, though, if you know of the periodontal ligament, if you remember studying that term or have just seen that when you yourself are at the dentist, those are the fibers in this fibrous joint, the gomphosis, holding the teeth into their sockets. For cartilaginous joints, there can be synchondroses or symphyses, I guess would be the plural. A symphysis, two symphyses. The synchondrosis, typically using hyaline cartilage. A symphysis, typically using fibrocartilage, and these are just some examples here. This is really kind of like locking together, same between the first rib and the sternum, which does not really move. The rest of the hyaline cartilage, these costosternal joints here, does have some flex to it. Right? The symphysis made of fibrocartilage, we have a pubic symphysis. This could be this pad as the two halves of the pelvis are coming together right at the anterior surface there. We do not have a mandibular symphysis, for we are primates, and primates have a fused mandible, but your cat or dog or sheep, if you have a sheep, why not? Right? Other things actually do have a mandibular symphysis between both halves of their mandible. All right. Now, most importantly, of course, this synovial joint. Synovial joints have an articular cartilage covering the ends of the bones that are going to be coming together. Bone grinding on bone just sounds nasty, right? We don't want that. The articular cartilages are going to be some extra padding. There is no connective tissue perichondrium over these like there would be over the costal cartilages, for example. A lot of water content to be nice and squishy. There's a joint capsule, all right, and holding the bones together will be a dense connective tissue structure, making this capsule, this space on the inside as well. There could be extra ligaments around the outside. Generally, there are a lot of ligaments. Now, the term ligament, all right, generally means a dense connective tissue structure that is holding bones together for stability. Generally, it means that there may be a couple of other places where you'll see something called a ligament, and it's not remotely connected to bones, but it is going to be probably dense connective tissue holding something together. Usually, though, when we say a ligament, we mean something holding bones together. The inside of the joint capsule is made of our eponymous synovial membrane, and it makes synovial fluid. Synovial fluid's largest role is as a lubricant, reducing friction inside here. It's pretty effective. Back in my day, kind of going into cadavers and cutting open, I'm thinking of the hip capsule there and kind of rubbing a finger, gloved finger, mind you, over the head of the femur and kind of doing that finger rub thing together. And you can really feel it's quite slick, and it's been tested versus industrial lubricants, and it holds up pretty well. But it will also provide a little bit of extra shock absorption, help nourish the cartilage a bit as well. So very important to have the synovial fluid. Where we have joints that are moving all the time, they are going to have synovial joints, even tiny little ones, really. So here's a generic synovial joint, and this is just a generic thing, just to show you what you might find if you were going to, say, go into, I don't know, the knuckles of the finger or something like that, because that's what this could be. Right, the articular cartilage, capsule. You have to actually cut into this capsular space to see the articular cartilage. Some extra ligaments here. Synovial membrane is just the inner lining, all right, of this, and that's going to fill this space. Probably somebody is thinking right now, or maybe actually cracking your knuckles. And now that I put that idea in your head, somebody else is doing it. Okay, that sound is just gas bubbles coming out of that synovial fluid. Nitrogen gas bubbles. It doesn't really have any deleterious effects. If your mother told you that, she just wanted you to stop. Okay, looking at synovial joints, classifying them by their shape. And now the reason I'm going through this, a little bit of review, it's not necessarily, though, to, I'm going to hammer you with a test or something on this, like you got back in 220 or something. But the broader idea of looking at the shapes of how bones are coming together and figuring out what they're capable of doing. And this is actually going to come into play also. The next topic that I'm going to blather on about is muscle. And so kind of looking at the connections, sort of figuring out what are the limits of this joint, and if a muscle is pulling, how is it going to affect this joint? What can this joint actually do? Some joints don't rotate. They move. They may kind of slide past one another, like two planes sliding past one another, or a little bit of wiggling, and that is called a gliding joint. Sometimes called a plane joint. All right, you can just kind of see the motion here. So if you were just shrugging your shoulders around, you can feel the sternoclavicular joint right here. Other ones like the intercarpal and intertarsal joints. As you just sort of wiggle your wrist around, wiggle your ankle around, of the little bones, the carpals and the tarsals in there, they're just kind of sliding past one another. There's probably going to be a lot of movement as they interact with the bones of the forearm and the leg. That's where most of the movement is going to be. But among themselves, giving some extra range of motion, little gliding motions there. The vertebrocostal joints, okay, just as you're breathing, all right, and your ribs are flexing out, not a lot of motion, but there is some. The basic joint shape that does provide a greater range of motion will be a hinge joint. Just one axis of rotation, and you'll see bones rotating, rotating perpendicular to the axis here. All right, so the elbow joint is a classic hinge joint, but really looking at the ulna on the humerus. Take the radius out of it. So if you put your fingers on the point of your elbow and flex and extend your elbow, all right, you'll feel that's all that can do. It doesn't matter what you're doing with the rest of your forearm, but the ulna is just going to flex and extend. All right. The knee joint's a really big one. The joints between the phalanges in your fingers. A pivot joint has one axis of rotation, but what makes it different from a hinge is the axis of rotation's parallel to the length of the bone, where it was perpendicular for the hinge joint. So don't see too much of these, but the atlas on the axis and the vertebral column, so when you're shaking your head no, a lot of that motion there is between the first and second cervical vertebrae. Right. Condylar joints, a few of these, it's sort of trying to be a ball and socket joint, but it doesn't have the ability to do a third degree of rotation. This would be, say, the knuckles of connecting your fingers to your hand, about how you can flex and extend, but also adduct and abduct, and I'm going to explain these terms very soon. Saddle joint's very specialized. It's really just here, all right, between one of the carpals called the trapezium and the first metacarpal. It's a slightly different shape, kind of two saddles coming together. Then the ball and socket of the shoulder and the hip, 3 degrees of rotation. You do all sorts of things with this, all right. So these are the only places where we have it. A true ball and socket is the shoulder and the hip. Whereas the head of the humerus goes into the glenoid cavity, or the head of the femur into what's called the acetabulum in the pelvis. All right, so some motion words here. I mentioned the terms flexion and extension. Flexion decreases an angle, extension increases an angle. And you can flex and extend lots and lots and lots of things. We see the flexion and extension of the entire vertebral column. It could be the neck, it could be the entire vertebral column. I mean, you can really kind of curl up, all right? Or extend it, all right, as you're standing straight or even leaning back. Now, when you go beyond 180 degrees straight, that would be called hyperextension. And you can hyperextend your neck and back to some degree, all right? Can you hyperextend your elbow? Yeah, but you may not like it. That's typically not really going to hyperextend. All right. However, looking here on the shoulder, yeah, you can bring your shoulder back. Depending on your personal flexibility, maybe quite a bit. Right. So we see flexion and extension for a lot of things. Circumduction, making circles. You see that with the shoulder and the hip. Abduction versus adduction. This is one that is very easy to mess up because there is only one letter difference here, right, when you're looking at this term here. Abduction versus adduction. We have a lowercase b and a lowercase d, and they look kind of similar, all right? What's the difference between a lowercase b and a lowercase d? I have 2 jokey answers for that. One is which side of the circle you put the straight line on, shape-wise. The other joke answer, there was a lowercase c is the difference. Yeah. Anyway, what do these words actually mean? Abduction, to take away. All right, and yeah, like abduction. Well, think about alien abduction, because that's kind of funny. Alien abduction, we're taking away, right? But we're going to move away from the midline of the body. And that's most evident here, as you see, with the shoulder. It's kind of an easy way to demonstrate that. But you can do it with the hip. Think about doing like jumping jacks. All right. When you do the one motion, to spread apart, that's abduction. Then adduction, the second part of the jumping jack, to bring everything back in, to add it back to the body, towards the midline, towards the trunk. Right. This can be done with other things as well. The wrist, abducting and adducting. Fingers can abduct or adduct down the midline, which would be on the middle finger. Right. Rotation, sometimes defined as lateral versus medial if you're going towards the side or towards the middle. Sometimes though it's just rotating left and right if you're actually on the middle. And a few other special ones. I mentioned early on prone and supine. Think about the body being supine or prone. Well, the forearm can actually be supine or prone. Thinking about the position of the palm. So in anatomic position, the palms are supine, or the forearms have been supinated, maybe a way to say that. And If you then go palm down, change the position of your forearm so the palm is down, they've been pronated. So it kind of, if you think about, I don't know, drawing a smiley face on your palm to represent the head, the face, then it works just the same way as anatomic position related, prone and supine, right? Face up versus face down. Okay. Now we can do that with our forearms. We do not have the ability to do that with our legs, feet, ankles. You may see the term pronate and supinate in relation to running, especially if you're buying athletic shoes. They may say like, okay, well, what's your gait? That has a little bit more to do with how, really what you would call rotation, medial or lateral rotation of your ankles in terms of like as you're coming down with each step when you are running. We cannot actually pronate or supinate in the legs, part of being a mammal. We keep our legs underneath us, tucked underneath. If you're looking at reptiles, though, crocodiles or big lizards, something like that, their limbs are all sprawled out, and they will actually pronate and supinate, moving the fibula and tibia relative to each other. All right, so kind of different. Anyway, a few other fun ones. Opposition, we have opposable thumbs. Pretty cool, can bring them together. The things that we do at the ankle, inversion versus eversion. Note how the sole of the foot pointing in for inversion, eversion pointing out. Due to some semantics here, we do not extend the ankle. Sometimes you'll see this as written as extension, but dorsiflexion versus plantar flexion is the best way to describe it, and that's actually because the way the ankle is built, right, we have the tibia coming down here, but we do have a projection in both ways. So when you're the heel bone, the calcaneus, does project posteriorly to where the tibia is. And so technically when you are standing straight up, you're at this sort of perpendicular angle here, and any motion up or down is going to cause one of these angles, either this one or this one, to decrease. That's why they're both flexion. So we would say, okay, well, which way are the toes pointing? Are they pointing towards the dorsum or the top of the foot? In that case, dorsiflexion. If the toes move down towards the plantar surface, the sole of the foot, that'd be plantar flexion. So if you go up on the balls of your feet to reach something, that's plantar flexion. If you go just so that your heels are the only thing touching the ground, that's dorsiflexion. 4 other motions here, and we see them relative to the mandible: elevation, depression, protraction, and retraction, up, down, forward, and back. On Wednesday, maybe Wednesday, we'll look kind of quickly at these motions applied to the scapula. All right. Probably more of that as we get into the upper limb. All right. Whew. That was joints. How about muscles? I mentioned earlier that muscles, when we say something like the pectoralis major, biceps brachii, it's more than just muscle tissue. There's a lot of connective tissue involved in terms of kind of keeping everything bound together and keeping it from kind of fraying apart with all the tension that is going to be generated. So don't worry too much about all this, but I will show you that here, each individual muscle cell can be very long. It's called a fiber. These are bundled into what are called fascicles. Fascicles are visible to the naked eye. For example, if you are cooking a pot roast or something, nice low and slow, all right? As you're cooking, you're going to be breaking down a lot of these connective tissue layers, and when you just kind of smash that low, slow cooked meat with a fork and it comes apart in all those little strings, those are the fascicles. Okay. The fascicles, though, will be bundled together with denser connective tissue, what's going to be called the epimysium, and that makes the muscle organ. All right. Now, muscles attach generally to bones, but sometimes to other dense connective tissue structures, and they do so through tendons. As I mentioned earlier, though, the tendon actually blends into the periosteum, not into the bone itself. Sometimes there are broad, flat muscles, like in the abdomen, and they have a broad, flat tendon. A broad, flat tendon has a special name. I'm just going to write this down here. An aponeurosis. I have no idea what the origin of this term is. But an aponeurosis is a broad, flat tendon. Some general rules of how muscles work. Right? Because we're going to be seeing muscles in all different areas, this is kind of important. The muscle has two attachment points. The origin and the insertion. I say it has two attachment points. Some muscles are going to have multiple origin sites. Right? Multiple places where the muscle begins and then kind of fuses together, possibly. Or maybe there's only one origin, that's fine. Only one insertion, though. The origin is going to be more stable. The insertion is the moving part. When a muscle contracts, the insertion is pulled towards the origin. And let me emphasize that. Muscles only pull. They cannot actually push. When you are doing a pushing motion, you're actually pulling from the opposite side. Okay? The action that is going to be done by a muscle when describing an action, you should use specific terms. That's what all those motion terms from the previous several slides, that's why I went through them. Because those are the technical terms that we should use. You should say flex and not bend, extend and not straighten. Right? That's the kind of the technical language that is being used. Right? So just a few other ideas with muscles. So when you're describing a motion, the muscle that does that motion can be called the agonist. Anything that opposes that would be an antagonist. Right? Now, I mentioned that thing about, hey, say flex, not bend, and here this textbook saying bend. So that's awesome. Thanks for helping me, textbook. Anyway, the agonist doing a motion, the antagonist opposing it. When examining to see, okay, well, what is the motion here? Remember, I said earlier, look at the shape of the joint and figure out what motions are possible with the joint. Insertions are pulled towards the origin, and generally what you're going to see is the origin is going to be proximal and the insertion is going to be distal. See what side of the joint the insertion tendon is going to cross over. Right? And that is going to give you an idea as to what is actually going to happen. For example, we know with the shape of the elbow, all right, the ulna and the radius on the elbow, let's just think of the elbow itself, not the pronation and supination. But at the elbow, the forearm is only going to flex and extend. When you cross anterior to that and pull this way, it is going to be flexion. The opposition, or if you're crossing on the posterior side of the elbow, and we see here the insertion of the triceps brachii on the olecranon process, the only thing this can do is extend. So we have these opposing pairs, and sometimes they may actually be working together. Say if you want to lock the elbow and prevent it from flexing or extending any more than it's already positioned. Right? A lot of muscles may help perform an action only in a certain position or otherwise help stabilize other joints, and you could call those synergists. All right, looking at nerves in general. So don't want to say too much on this. A nerve, however, is going to be a bundle of axons. Axons are the part of a neuron that is really, really long, and it's going to be conducting the electric signal. Kind of think about like an electrical wire. Because they're long and skinny, sometimes axons of a neuron are called neural fibers. The word fiber has like 300 different uses in science and anatomy in particular. Like a neural fiber, though, is an axon. These are going to be bundled together, actually also in fascicles, and then wrapped together in dense connective tissue to make the nerve itself. The organization is actually rather similar to what was seen in muscle. All right, the axons are actually in here. There are nerves traveling throughout the body, and one thing that I want to mention with it, again, if you are ever dealing with this situation in a cadaver, or possibly in a living patient, and you're not sure exactly what a structure is because you're seeing a whole lot of like long skinny things coming out. You're like, okay, is this a nerve? Is this a blood vessel? What's up? Nerves are more or less solid, right? It's not going to compress because this is full of structures, right? So kind of putting a little squeeze on it, and again, yeah, this is why better cadaver than a living patient. Putting a squeeze on this, it's going to be incompressible. It's not really going to push in, right? As opposed to a blood vessel, or an artery or a vein, which these will compress. Now the difference between them, though, is an artery will spring back, whereas the vein can stay collapsed. Now this is, again, assuming cadaver drained the blood, etc. That's what you will see. The reason is the artery is going to have a thicker wall with a lot of elastic fibers inside of it. Veins have a larger lumen, the space inside, and thinner walls. Right? Most blood at any given time is going to be in the systemic veins, not the arteries. In the veins, it's kind of taking the slow crawl back to the heart. Blood in arterial circulation, though, is rather fast moving, and this all has to do with pressure. Arteries take blood away from the heart. So the heart squeezes, generates a lot of pressure. That pressure goes into the artery, sends the blood coursing along. The artery is going to expand and then recoil because of these elastic fibers in there and help maintain that pressure as the arteries branch into smaller and smaller arteries and go into the capillary beds. Capillaries are super small. They are the sites of exchange of gases and nutrients and wastes and everything between the blood and the body tissues. And in the capillary bed, as this exchange is happening, the pressure had been kind of dropping, but now it's just going to plummet. It's going to be very low, and then the exchange has occurred. Capillary beds will drain into veins. The veins are going to drain into larger and larger and larger veins. But these are all under very low pressure. And in fact, one consequence of the low pressure is that they may need valves. And I thought I had a picture of the valve, and it turns out I don't, but that's fine. But some veins actually have valves on the inside of them to prevent the blood from actually moving backwards. All right, a real quick view here just of circulation in general. 2 circuits. All right, the heart is going to be a kind of a big topic, heart and lungs actually, for Friday. So seeing the interaction here of blood from the right side of the heart being sent out into the pulmonary circuit. All right, the artery is going towards the lungs, to pick up oxygen. Pulmonary veins returning freshly oxygenated blood to the left side of the heart. The left side of the heart pumps blood into the systemic circuit, and from here it's going everywhere. All right, we have branches going into the upper portion of the body, to the head and neck, the upper limbs, the thorax, and going below the diaphragm into the abdominopelvic cavity, lower limb areas. All right. 2 major ways to get back into the right atrium: the superior vena cava, the inferior vena cava, right, depending on where the blood came from. There's a special thing right here, all right, that we'll be looking at next week, I'm guessing. The hepatic portal system, where blood from most abdominal organs actually goes into the liver before it can re-enter regular circulation. That's going to the liver for processing first. Right. That's the general idea. Now, one little thing about the color. First of all, this blue color, not quite that blue. All right. Oxygenated blood is pretty red. It is pretty bright, owing to the actual oxidation of the iron in the hemoglobin. When it's been deoxygenated, you're going to get a darker red, maybe burgundy kind of color, not quite even violet or anything like that, but it won't be like blue, all right, in that way. But however, this blue colors are typically used to represent deoxygenated blood in all sorts of anatomy diagrams and models. Because in the systemic circuit, which is most of the blood vessels of the body, the arteries carry oxygenated blood, you may think, oh, red equals an artery and blue equals a vein. That is not entirely true. In the pulmonary circuit here, note the blue color used for the pulmonary arteries, the red color for the pulmonary veins, because the color is oxygen content, and it is reversed in the pulmonary circuit. All right, last topic, just looking at one final thing that is spread throughout the body, and that would be the lymphatics. Lymphatics, probably throughout the course of the semester, I'll mention it here and there, not too much. The lymphatic vessels are going to be found kind of paralleling most blood vessels throughout the body. They're very thin-walled, and they do not make a circuit. They instead make a unidirectional path. Starting at the level of lymphatic capillaries, that's where they begin, and then they'll drain into slightly larger and larger lymphatic vessels until they plug into the two subclavian veins, getting close to returning blood back into the right atrium of the heart. The job of these lymphatic vessels is to pick up extra fluid that is just going to be outside, but among the body cells in body tissues. As part of the exchange of material that happens in capillary beds, some water volume is lost from the blood, and this is going to return that back in. All right, so we'll just see very low pressure, very thin wall, parallel motion. They do need valves, and you can actually see the valve here in this microscopic section. Now, along the way, though, the lymph is going to get filtered in lymph nodes. And there are lymph nodes in lots of different places on the body. Typically, you'll find them in the neck, the cervical area, the axilla, the armpit, the inguinal region, which is kind of the groin where the lower limb is rejoining into the trunk, in the intestinal area. So what unites all of these is actually places where we're kind of rejoining the main trunk. All right? And lots of different lymph nodes. Lymph nodes are going to filter the lymph. And in this lymphatic tissue, there are places where you would find different immune cells. Lymphocytes, macrophages, things like that. Note that a lot of what are called afferent lymphatic vessels bringing lymph in, but typically just one way out, one efferent pathway out. So the lymph is forced, and the lymph is the name of the fluid traveling through here, is forced to move through this network. Things inside of the lymph can get caught here and scanned or destroyed by the immune cells in this area. Potentially then, if things are really, accumulating, you may get a widespread immune response occurring. The production of many lymphocytes to fight off whatever it was that actually caused this reaction to take place. All right, well, that is it for the intro of stuff that's throughout the body. Starting on Wednesday, we'll get into kind of the specifics of region by region, bit by bit.